Welcome everyone to the Lifebulb seminar focused on transplantation, organ transplantation, and the role that social work has in organ transplantation. My name is Karin Hieberger. I am the CEO and founder of Lifebulb, and I'm also a two-time organ transplant recipient. I received a kidney transplant 14 years ago, almost exactly, March 12th, 2009. And a pancreas transplant 13 years ago. So I am a patient, I am a trained physician, and I am now also leading our effort in trying to build a community for patients, care partners, and everyone affected by this condition. And what I have experienced in my world here with transplant is the importance of more than just the doctor. There's really a role for a team in the transplant. It's a complicated process, and I'm delighted to be joined today by two incredible social workers, Tiffany, Coco, and Kristin. And they're not just social workers who lead a practice, but they have also created a new effort called BEATS. So I think we'll have a really interesting conversation here today, where we're going to learn more about what social work, how important social work is for the transplant process, not just the evaluation of whether you're eligible for a transplant and the process of the surgery and the few weeks, months afterwards, but what is the role over the entire process? Because as you know, living with a transplant is not a one-year-long journey. So welcome, Tiffany and Kristin. Maybe please a few words, just why you got into this space and why did you create BEATS? Maybe Kristin, if you want to start.
Sure. So thank you so much for starters for having us on. This is such a huge honor, and I'm so excited to meet all of you virtually and to get to share the world that we are so passionate about, which is social work. So just briefly about myself, I am a social worker in Texas, and I work with a transplant program, specifically heart, lung, and also LVAD. But the reason that we started this, and
what's LVAD?
Oh, thank you. So LVAD is left ventricular assist device. And so that is a device for patients who may not be a candidate for a heart transplant for some reason, or may need an additional medical support while they wait for a heart transplant. And the reason that we got started in this endeavor for BEATS by Social Work, and Tiffany, I will also let share as well, but is because we noticed that just like you were mentioning, that a lot of people remember their surgeon, their primary physician, their nursing team. There is very little recognition or resources available to the social work community that work with transplant patients. And as Tiffany puts it, and not to take her words or her opportunity, but if it wasn't out there, we need to create it. And so we found each other virtually and decided to create it.
Tiffany.
Yeah, so I'm Tiffany. I am a social work education specialist, which is a new and unique role, but I got my start in working with lung patients and living donor. And then I moved out to Arizona to become a heart and left ventricular assist device social worker for several years. And just recently moved into this role where now I get to assist other social workers reach the top of their level and help train them and make sure that they have the correct tools that are necessary for being able to do their practice. So I fell in love with the world of transplants early on, many years ago. And even though I might not be working direct patient care any longer, I can't take the girl out of transplant. And so, as Kristin said, this is something where her and I were both very into podcasts and, you know, something to fuel us outside of conferences and outside of educational opportunities. And we realized that there weren't a lot that related, well, none to be direct, that related to transplant. There was webinars, there were podcasts that related to it from a clinical and medical perspective, but not from the psychosocial,
Mm.
and to bring that community. And that's really what it's about, is the community of social workers together to feel that they're heard and to feel that they're seen. And as Kristin said, it's one of my favorite ways to put it is, if something doesn't exist, well, we're going to make it. And especially this being Social Work Month, the theme of this month is breaking barriers. And I like to say that Kristin and I were doing that before that was the theme.
Fantastic. That's really great. That it's always hard to be the first. So I can imagine there've been a lot of struggles, but probably also huge opportunities. And I'm sure that many of your former colleagues and colleagues are grateful to get this outlet. So if we just go back to, from the patient perspective, as a social worker in transplant, just briefly, what are the main roles that you fill? If you take us through the journey of evaluation, transplant, year one and beyond.
Yeah, I think that the role that we fill it's a hard question, because it's more of, what don't we fill? We fill in the gaps as the social workers,
Mhm.
and we wear many hats. I like to say that we're like the multi-tool of the multidisciplinary team, because we do a little bit of everything. But the technical description and versions that are out there, according to CMS, according to the Society of Transplant Social Worker, according to UNOS, is we're going to be doing a psychosocial assessment to determine who are they, who is this person, learn more about them, learn where their areas for opportunity for growth are, where there might be some barriers, to see what we can overcome, looking at them from the perspective of being able to be a transplant candidate, helping them develop a plan. We provide them with support, we provide education. We are helping them with the transition back to employment post. We're helping them really, as you said, all phases, and we're going to kind of break it up a little bit, but the pre-phase, the filling in that information, the peri phase, so the during and kind of the waiting, and then the post phase, and that's the marathon. I always say that there's 3 hurdles when it comes to transplant. The first hurdle is are you a candidate?
Mm-hmm.
The second hurdle is, does a call come? Because we all know that just because you're a candidate doesn't mean that you're going to get the call. And if we jump that hurdle, we jump into the marathon of, did the surgery, was it successful? Were you discharged from the hospital? And are you able to adjust? So my kind of little nugget that I like to say is that the hurdles of transplant, and we're there for all of them. And, I'll go over to Kristin to talk a little bit about the pre-phase.
Absolutely. And so Tiffany already mentioned quite a few of the main components for that evaluation piece. Like, why do we ask it? I like to tell my patients that I am so sorry, but I get to be the one to come in and ask all the nosy questions, but there is a reason behind it. And while the doctors are coming in and running all these tests and trying to figure out if you're a good medical candidate, we're the ones that put a face and a name, you and your family, to all the scans that they're showing to the medical review board or the selection committee. And so we're the ones that help paint that picture of you as a whole. And so we also try to navigate any potential barriers. So we're going to look at resources. We are going to look at assistance potentially with housing, transportation to appointments, and even potentially immigration issues that a patient or family member may face, or a potential caregiver. We're going to look at disability benefits, your retirement benefits, and help you navigate if you were working before, or if you need to utilize federal funding or your community's resources. We also help with that emotional adjustment at every phase, but particularly in the pre-phase, we help facilitate education as a whole, but we're also going to encourage you to attend support groups. And yes, we do ask a lot of nosy questions. That also helps us to make referrals as needed too. And so again, it's that breaking of barriers. So if we see that in the midst of our investigation work, you might benefit from a referral to a neuropsychologist or a psychiatrist, or a vocational rehab. There's a lot of resources out there, but we're not going to know what best to utilize until we get to ask all those nosy questions. And then also drawing in your family and social support. That's going to be a big part of it as well, because the transplant process is a family and system treatment option, not just a patient. It takes cheerleader, coach, pep squad, and training team to make it work.
So just a question on that, because it's a lot of evaluation, what you're talking about, and it's assessment and questions. And what is your role as, because I know that especially some social workers also become more therapists, or they can take a role as a therapist. So if you identify a need, a practical need, you can try to fix it by identifying a new job opportunity, or do you kind of do both the pull and push? I mean, do you evaluate and solve, or do you mostly evaluate and turf? If you see what I'm saying, are you the person who's sitting on top of the questions, and then you say, oh, that person needs this to be eligible, or that person needs that to be successful? Or do you ever come in and say, that person actually needs another social worker, or a therapist, or even myself? Or do you see what I'm saying? The role can be manifold.
I'll jump in real quick and say that it's all of the above. Clear as mud, right? But when we're doing that evaluation, especially that initial one, it's identifying the gaps. And it is looking to see, are we able to overcome that? There are some areas, some barriers that we may not be able to overcome, but we're going to do our best to. And that's why we have to ask so many of those nosy questions, is to really know, is that something that we need the therapeutic portion that could be done by us, or if it's going to be something that needs to be done a little bit more frequently, and we don't have the bandwidth to be able to see a patient as frequently as they need for that therapy. Is it a community referral? Is it something that we can help them with because we have those resources or can connect them to those resources? So it really is that whole spectrum of all the questions that you're just posing. That's kind of what our job is to figure out what bucket each one goes into. And really,
it's like the role of a social worker is it's incredibly important to be well networked and have good connections. So as a young social worker, do you often work with a mentor, or do you get thrown into your own work quickly?
Well, I'll jump in on that one. So particularly with transplant programs, and I will also add left ventricular assist device programs that may or may not have an affiliation with a transplant program. A lot of times the social worker finds themselves wearing many hats. And we often say too that the reason we started this podcast is because a lot of our social worker colleagues across the country and beyond feel like they're on an island. And so how do we bridge these islands? And so, yes, there's a lot of mentorship programs available. One that I will just give a shout out to is the mentorship program through the Society of Transplant Social Workers. They have an excellent mentorship program, but there's also quite a few with other professional affiliations. But you're absolutely right. A lot of times when someone is chronically ill and is in the hospital, and either prior to having transplant discussed with them, or if that's not on the table whatsoever, most of the time their exposure to a social worker is exclusively as a discharge planner. So what medical equipment do you need? What resources do you need? Home health, nursing, that sort of thing. And it's very much a little bitty telescopic view of the patient, whereas we look at the panoramic view. And so we have to shift our lens a bit. And so from a licensure standpoint, we are licensed clinical social workers, which does mean that we hold the same licensure as many of the mental health practitioners that have a private practice. We do have that capability, but as Tiffany was saying, we're juggling many hats. And if somebody does have a therapeutic need, that would be best served on an ongoing basis. And unfortunately, that's not something that we would best serve. So we would make a referral at that point.
So I was going to ask a very categorical question that you probably won't like, but I'm going to ask it. You know, as I see it, as now that I understand more, a psychologist and a social worker may face similar problems in a patient. A patient may be struggling emotionally and may not be able to handle, you know, this very complex journey of transplant. But a psychologist may dig deep into the mental state, while a social worker will start by solving the practical issues. That it could be their family situation, their lack of a job, or food desert, or am I on the right track, that you're starting with macro, they start with micro, or is that totally wrong?
So we start where the patient is.
Mm-hmm.
That's the thing. That's one of the biggest differences, I think, with the field of social work, is truly we go to where the patient is, meet them where they're. That's basic social work 101. But one of my favorite quotes or memes, however you want to call it, I found a couple years ago is, you know, psychologists, they ask a person whether they believe the glass is half full, half empty. Yet social work asks if they know that the glass is refillable, and who or what is stopping them from accessing the tap. So we love our psychology colleagues, but it's a little bit of a difference, and we do refer to them as necessary, but we are meeting them right there to say, do you know that's a refillable cup? And why aren't we refilling it? Is it because you don't know how? Is it because you don't want to?
Yeah.
Is it, what's the underlying? And that's something that we have to get to. And sometimes, as Kristin had mentioned, we're doing that in a very short period of time. If we have a heart patient or a lung patient, sometimes we are faced with, we're getting all this information and going to discuss their case the next day, maybe even the same day. And so we have to get as much and as in detailed questions to determine if we can help them in the long run. Because it's also, we think about that, we follow them throughout their spectrum. So we have to also know, are we setting them up for success and long-term success, not just getting through that surgery, but what does the rest of their life look like?
Do you operate your life this way? I mean, this is, again, do you see, because it is fantastic. I would love to have a social worker with me all the time, you know, because life is always a mess. In my I mean, there are always things that can go wrong, right? And if you sit down and you start distilling and you think about where you are, you can probably put the puzzle back together if you're logical and you can piece it together. So I just wonder, are you as a social worker very practical in mind often, you know, in the rest of your colleagues? Is that a characteristic?
I think we're both laughing because the answer we know is yes. But it's also that sometimes I think that the bandwidth of our brains is because we're very passionate about our work and our patients and what we do. A lot of bandwidth goes to that. And so what that means is I might find my keys in the freezer and have no idea why it got there. But I think that can be said for any passionate professional.
For sure. No, I'm joking somewhat, but I do think that most professions attract, you know, the characteristics that are appropriate for that profession.
For sure.
I think for sure. You know, if we go back to, it's a question from the audience, and it's also something I'm highly interested in as a post-transplant patient. You know, what's the role of the social worker? You did talk about the 3 phases, but where we mostly see social worker really is the first phase and the discharge. Where we see a lack of social work, most of us at least as transplant patients, is this continuation of the marathon. And is it because there's a lack of social workers, or is it less interesting for social workers to be involved there?
You know, when it comes to the post, each institution works a little bit differently. And in the pre-phase and even the peri-phase, so during the hospitalization, you should see your social worker as well. Your social worker, you know, part of the requirements are that we are doing a check-in right after the surgery. We call it a post-op day 1, and then supportive visits during that. Sometimes kidneys, for instance, may not be in the hospital, but only a couple of days. So you only get, one visit maybe with them. But there's regulatory boards for the pre and peri. There's guidelines for the institution of how frequent you need to see them, or how long your psychosocial lasts, things like that. Whereas post, the regulatory is that you're available. And so some institutions look at that differently. Does that mean there's a timeline or a protocol on you see that patient at the 3-month mark and then not again at the 3, 6, 9-month mark, at the 1 year, things like that. So that could be where different people have different kind of touch points with their social worker. They're still available. And that is where sometimes actually the most of our work is done in the post, because that's where you're living life. And life changes, life happens. As you said, life's messy. And so all of a sudden you're cruising along doing well for 3 years, and then something happens. There's a divorce, there is a change in job, which means change in insurance. There's a lost job because the economy, whatever it might be. And so now all of a sudden you're faced with these emotions that are coming up. These all of a sudden, I'm not coping as well as I was, or I can't afford my medications now. So that's where we get involved as well. Now, that's some patients don't realize that I can still utilize my social worker. So that's something too that we want to speak up and pose and just advocate, or empower rather, for you to advocate for yourselves to call and say, I need to talk with my social worker.
I think that's really important. And I think that's a message to our community, is that do ask for your social worker when you do feel that life is too messy. I think that's really clear, and we should make sure everyone knows that. Just a slight correction, since I come from the kidney pancreas world, the average time for a kidney is about 7 days in the hospital. So I have never heard of a kidney of 2 days unless they're a donor. But just for our audience, since we have a lot of kidney patients in our audience as well, so they don't feel that they were slackers when they spent a little longer.
We have at our institutions, we are actually able to get them out. A couple of them in 3 days, 3 to 5. Yeah. So sorry, that's where I was coming from.
3 to 5 and then 2. Anyway, but that's okay. So we are actually heading toward our finish here, but I want to give you a little bit more of an opportunity to talk about beats as well. And so this is an education for other social workers, but what are you doing to spread the word to more patients? How do you think you can grow the social work community to help more patients in this transplant community? Partnerships with Transplant Life, would there be, do you have any thoughts?
So I'll jump in with this. And one of the main reasons, or one of the main ways, I correct myself, that we can help our transplant community the best is to bring more awareness and bring more education into the world of medical trauma. And so that's one of our big passions with Beats by Social Work, is we want to get the education out there. We want to ask the questions that when we were newer social workers, we may not have been brave enough or have had the ability to ask. And so medical trauma is one of those components that is not talked about enough. The resources are underutilized. Everybody is still of the mindset, or I won't say everybody, of course, that's too all-encompassing, but a vast majority of people are not educated in a trauma-informed approach and just assume that PTSD is for those who were combat veterans or something along those lines, that PTSD just fits in the VA box. And that's not the case. There's more and more research coming out that shows that staying in the ICU is a traumatizing event, and a capital T trauma at that, not just a lowercase t, for those who may have heard that jargon before. And so that's really where social workers can expand their wings and can really help the transplant community as a whole.
Mm-hmm. That's great. It's very, very, I think we see it a lot in our discussion forum, how PTSD is being discussed and how patients are struggling with even going back to the hospital, again, and that can cause issues with adherence and and visits when there are traumatizing, events associated with transplant.
Absolutely. And if I may add just an additional thing that, and this is not to speak negatively of our interdisciplinary team, but the reality is that not all professionals that transplant patients come across are going to be trauma informed and educated in trauma. So sometimes post-transplant, you may experience professionals along your journey who say, what do you mean you're experiencing that? Shouldn't you be grateful for the gift of life? You shouldn't be sad. You should be happy. But those are all very normal feelings and all very normal ways to adjust to trauma. And so to utilize those resources to help get involved with your social worker who is trauma informed is going to be a big part of that.
Mm-hmm. So how are you intending now with Beats to bring on more patients? Are you looking for patients to be part of your podcast, or are you mostly speaking to other colleagues? I know that we've had one of our ambassadors on, and you want to talk a little bit about how that experience was?
Yeah, that was, as we say, we are for other transplant social workers, but we also do it because we want to raise awareness about transplant and LVAD social work. So for the patients and helping the patients even understand maybe why their social worker is asking these questions, or why they have to go through all of this, or even helping process, because sometimes it's really hard to put a name with your feelings and to know that I'm experiencing this. I've never experienced it before. Why is that? So we're unpacking the things that we don't have time to unpack during that initial psychosocial, or during those post appointments or therapeutic sessions. And so it is being available to not just other social workers, but to patients to help them learn more. Being able to interview with your ambassador was wonderful because it is allowing the patients in a more laid back and informal area too, to talk about their experience versus, maybe the we say white coat anxiety of talking about it in the medical center with us. So it's wonderful. And part of a piece that we're putting together of talking with some patients from different organ groups to incorporate what it was like to go through it, and how important and or difficult it was for having support or not having support, and integrating back into life. And so it's part of a series that we're going to be doing, be on the lookout for that in the future. Yeah. But it was wonderful to be able to speak, and knowing that we weren't her social workers, so we were able to really speak even more in depth about what it was like to have that experience with a social worker, or if you didn't, how we can be better.
So, one of the reasons why people don't get placed on the list is because they have a lack of social support. And unfortunately, or they're deemed psychologically not eligible to handle a transplant process, maybe not be able to adherent or get to the transplant center. And unfortunately, that affects minorities more than it should, right? And the largest, I know you're not representing that, but the largest transplant group is the kidney, and within the kidney population, you have a very large African American and Latino population. So within the social group, population, do you have a good distribution of minorities represented as well, who can handle these kind of issues that may be better handled by a peer? You're saying you're meeting the patient where they are, but if you're coming from a perspective of a white Caucasian woman, and you're dealing maybe with a Latino man, may be more difficult to handle.
So that's a really good question. And one of the components, or one of the big pieces to our code of ethics, is cultural competence. And so I personally work in the most diverse city in America, in the largest medical center in the world. And so diversity is, no pun intended or pun intended, our second language. And so we do have, in terms of employment, our social work community is diverse. But I do believe that one of the things that sets us apart as a professional is that we utilize our cultural competence as a major part of our code of ethics. And so if we are not able to refer to a social worker who is of the same cultural, racial, and ethnic group, then we are going to do our best to learn about their culture and their practices, but also ask with humility, what is your preference and how can I best serve you? In fact, I finish every single one of my social work assessments with, what did I not ask that's going to make me a better social worker to you? What do I need to learn about you that will make me better for you? But we do ask about culture and cultural practices to make sure that we are being sensitive in that arena.
Yeah, I can imagine that's highly different in when you come from a different background, you know, how things are going to be handled outside.
Absolutely.
Yeah. Great. Any final greetings to our audience? Anything you want to say? Anything that I missed asking to go to your point?
Tiffany, if you would like to go first.
I think that the one thing that we didn't touch on that I wanted, it could be its own category, but I want to bring it up briefly. It's very near and dear to my heart, is talking about the donors. I know that's always a big topic, and as a recipient, you know, knowing about who gave this person, who was this person that gave me this gift, and, you know, talking about, we see it on television, we see it on the news of people being able to know who their donor was, but to realize that that is a rarity, and that's why it is highlighted. Majority of the people, in fact, do not hear from their donor family. And just taking it a step back for a moment, one of the things I say in a loving and joking, but curiosity killed the graft, because we talk about you know, your organ as a graft, and sometimes it is very easy to get focused and almost fixated on hearing from your donor family, but just remembering that that donor family is going through a time of adjustment as well. Just as you are learning how to take your meds appropriately and how to be a transplant recipient, how to live life that you can actually live again, this donor family is learning to live without. And they're getting through those first birthdays without that person. Who's taking over the role that that person filled in their life. And so knowing that writing to them to say thank you means more than you could even know. But sometimes, because of family dynamics and things that have happened within that family, they may not be able to write back to you. So I just want to put that out there of, your letters do mean something, but just because of life and circumstances, they may not hear back from you. And that's okay, because they gave you the biggest gift, right? And I know we still want to know sometimes, but just knowing that they made the decision, and that family made the decision at one of the hardest times of their life to give life, and how beautiful.
Wonderful. I think that's very important to think about. So thank you so much. I really appreciate the time and the education, and really learning more about social work and the importance of social work, which we all knew, but I think we've learned more about what it actually involves. And it's really impressive. Takes a lot of education, and I think you're also sitting on top of really interesting data. So I can imagine that as a social worker, there's a lot of research that can be done, and, you know, publications and important data that can come out from a quality of life perspective and outcomes. I'd love to talk to you further about that as we build our community on transplant life and see more and more people coming along, and just really understanding what are the big quality of life issues, and what can we do for transplant patients to truly improve every single day. Because right now, the outcomes that we look at in transplant are mortality and graft survival. And that's not enough. You know, if you've had your graft for 14, 15 years, but during those 14, 15 years, 4 or 5 of them have been bad, that's never registered in any you know, documents. So
you're exactly right.
We do need to get to better quality of life and PROs, meaning patient reported outcomes. And I think the only way we can do that is to involve more patients into research. So
Absolutely.
thinking about getting patients involved into research, we are running a workshop end of this month, and that workshop we are still looking for patients. So if you or anyone on this call, this webinar, if you know of individuals post-transplant, kidney transplant, and people also pre-kidney transplant who are on the list, who would like to participate in a virtual workshop where you are paid per hour to participate and you can impact the future, please let us know. Because this is the only way we can change the future. And right now, transplant drugs are antiquated. We are dealing with very old drugs and we're dealing with old processes. We are very grateful to be alive, but I think our quality of life could be much better if we had more innovation. I'm going to end with that and thank both of you so much. And I hope we can collaborate on research going forward. So
Yes. Thank you
Thank you.
so much. They don't call us social work scientists for nothing. So thank you. Thank you.
Yes. Thank you so much for letting us be here. It was a pleasure.
Thank you. Bye-bye now.